Good afternoon, morning, or evening, everybody, depending on when you're listening to this podcast, coming to you from Mayo Clinic in Rochester, Minnesota. I am Kyle Klarich, and I'm one of the cardiologists here on staff. And today we have a fascinating topic, genomics and inflammatory cardiomyopathies. And we are honored to have one of the world's experts in this area, Dr. Naveen Pereira, who is a professor of medicine in the Department of Cardiovascular Diseases, associate professor of pharmacology in the Department of Molecular Pharmacology and Experimental Therapeutics, and chair of clinical trials operations and medical director of clinical trials at Mayo Clinic. But basically, I know Naveen as a phenomenal heart failure transplant physician and clinician with a clinical and research interest in genomics. He's really well versed in this. And if you could see his whole CV, which would take our entire podcast to share with you, he's done a ton of research, had many awards in this area. So we are really happy to have you here, Naveen, to discuss with us the genomics of inflammatory cardiomyopathies.
Thank you, Kyle. It's really a pleasure to be here with you. And thank you for this opportunity.
I was wondering, just when I heard the title of what we were going to talk about today and did just a little bit of reviewing of some of the things that you've done, it's clear that heart failure and ventricular arrhythmias can have an inflammatory origin in heart disease, such as myocarditis and sarcoidosis. So I'm wondering if you could just start, for those of us like me that don't know a lot about this area, how do inflammatory cardiomyopathies typically present?
Right. And so what's really interesting is I believe that we are making a diagnosis more often. If you recall, 20 plus years ago, imaging techniques were not that good. And most of the times when we clinically suspected inflammatory heart disease, we did a biopsy and proved whether a person had inflammatory heart disease or not. And the whole biopsy situation we can talk about in detail, but it really has poor sensitivity and specificity because it depends where you biopsy. And there's always a question of sampling error. But when do we start thinking about inflammatory heart disease? So when patients present now with acute onset heart failure with reduced ejection fraction, we always wonder if this is myocarditis, especially if there are diffuse T-wave changes on the ECG. Sometimes patients may have significant ventricular arrhythmias. And when we see a lot of arrhythmic activity, we wonder if there's inflammation, because things like giant cell myocarditis presents in a very fulminant way. Arrhythmias are a hallmark. Patients with sarcoidosis, for example, can have complete heart block, second or third degree heart block. And especially in a younger person, having that raises the suspicion for sarcoidosis. So acute onset heart failure marked by conduction tissue disease, whether it's AV block or ventricular arrhythmias, including atrial arrhythmias, one suspects the possibility of inflammation. And now most of our practice has moved to doing cardiac MRI in new onset heart failure reduced EF, because we want to make sure we rule out, other secondary causes, especially inflammatory heart disease. So we are also incidentally now picking up evidence of inflammation by MRI. That's why I really feel that as we move to more imaging in patients with new onset heart failure with reduced ejection fraction, we are increasingly seeing more inflammatory heart disease diagnosed.
Fascinating. So it sounds like you would suspect it, you'd start to look for this in a patient that has relatively recent, if not acute, onset of heart failure with reduced ejection fraction. So typically in my world as an echocardiographer, that would be, patients admitted to the hospital with shortness of breath or chest pain or some combination of those things, comes to the echo lab, we get a low ejection fraction. And then the next step for you would be some sort of imaging modality. And you said, more than likely today's world, cardiac MRI.
Yeah, exactly.
So is there a role at all for biopsy in these in these patients? Are
Right.
is it or how do you then? So now the MRI. Tell me how the MRI will come back. That you would then. How would you follow that to either a biopsy or other diagnostic testing that you might order in that situation?
Right. And the MRI also, by the way, is complemented now with PET cardiac imaging studies. So we are, now increasingly well done with a well organized protocol and patient preparation. PET cardiac imaging also corroborates the MRI findings. So, of course, when you see increased FDG uptake and you see mismatches, you suspect that there's ongoing cardiac inflammation. The MRI, by T2 imaging, you see edema, and then you get late gadolinium enhancement, and sometimes you wonder if that's active inflammation or scar. And so PET imaging complements those. The problem is unless this is diffuse myocarditis, like with sarcoidosis, for example, there's patchy involvement. And so when you do a biopsy, the biotomes are geared to going to really the right ventricular aspect of the interventricular septum, closer towards the apex. And you may miss getting the area of inflammation. And so it's become better with what is known as electroanatomic mapping or intracardiac electrogram, a guided biopsy. So sometimes you do biopsies in conjunction with imaging. You kind of map out, by PET CT or cardiac MRI, which areas you want to target. But those become technically challenging, but the diagnostic yield can increase. But really, I mean, what has happened is people have moved away from biopsies. And if you have the MRI and PET imaging studies both positive for inflammation, a diagnosis is made. And most of these patients then get diagnosed with isolated cardiac sarcoidosis. And that's where our recent paper in Circulation Genomics and Precision Medicine, I think, is important, because what we found is 21% of these patients with presumed cardiac sarcoidosis, and it's called presumed because imaging studies suggest inflammation and the clinical presentation of AV block, arrhythmias, low EF, support the clinical diagnosis. And we found 21% of these patients in our cardiac sarcoidosis clinic actually had a likely pathogenic genetic variant in one of the cardiomyopathy genes. And so you wonder then, is this really cardiac sarcoidosis, or is this a genetic cardiomyopathy that's really masquerading as inflammatory heart disease or has aspects of inflammation? And the first paper was published several years ago, and it showed that desmoplakin, one of the proteins very important for intercellular communication, adhesion, etc. So desmoplakin cardiomyopathies were classically associated with these inflammatory findings on imaging. And the diagnosis is really, it's a desmoplakin cardiomyopathy. It's a genetic cardiomyopathy, but it has inflammatory features. So what? Yeah, go ahead.
Stop you there. So if I get this whole imaging package that looks like sarcoid, and I don't test genetics, I could go down treating this patient for sarcoid. Would that be the wrong thing to do? Because
right. Well,
cardiomyopathy. I mean, to help me understand that, because this is 21%. It's not an insignificant number of patients.
No, absolutely, Kyle. So it becomes really important, So what we're suggesting with this paper is that we have to do an additional layer of phenotype. In fact, in that case series of patients, 60% of those patients did get started on immunosuppression before it was known that this was a genetic cardiomyopathy. And so here's the dilemma we have right now. So if there's actual inflammation, whether it's triggered by the gene or whether this is inflammation induced by sarcoidosis or other inflammatory myocarditis, um, immunosuppression, as you know, is the mainstay therapy for active cardiac sarcoidosis. And so there aren't good trials showing the benefit of immunosuppression, but steroids, we use MMF and other drugs, methotrexate, etc. And it's more commonly clinically used if we really think this is sarcoidosis, but we don't know what to do with the genetic cardiomyopathy patients who present with inflammation. And so what we have to do is add, after you see inflammation by imaging, PET, MRI, we suggest adding this layer of genetic testing as part of the phenotyping of the patient. And whether, if they are gene positive, whether to do embark on immunosuppression, we have no idea, because this is now just newly recognized. And it's a relatively rare disease. So as you know, doing a cardiac randomized clinical trial is challenging in a small number of patients.
Just a couple other follow-up questions based on that. So 21% of the patients that were originally diagnosed by imaging techniques when you ran the genomics ended up having the desmoplatin gene, which was an inflammatory. Am I right?
Well, actually, what was unique about our paper was there were multiple genes.
Oh.
So what originally started off as, a description of desmoplakin presenting as inflammatory cardiomyopathies, it turns out now that in our study and in others have shown that any other gene can also present with this inflammatory pattern. So we had LMNA, NRAS, and FHL1, and things like that, which we described in the paper. Yeah. So it could be other genes too.
Excuse me, but do we know the natural history of some of these genes? We probably don't even really know the natural history. Am I right?
Well, in general, patients who have a genetic cause of cardiomyopathy do worse than those who don't have an identified genetic cause of cardiomyopathy in general. It doesn't mean, a lot of these patients with a genetic cause of cardiomyopathy can respond to medical therapy and should be treated, with standard guideline-directed medical therapy. But despite therapy in general, patients do worse. And then within the genes, some have a worse prognosis than others. So titin is very common. But I would say a gene like LMNA, the laminopathies, the course is far more malignant than, say, someone with a titin gene mutation. So we kind of know the natural history of genetic cardiomyopathies, and I would say the take-home would be, in general, the genetic cardiomyopathies do worse than the non-genetic dilated cardiomyopathies.
So the person that's going to see these first is the general cardiologist, the heart failure cardiologist. They're going to go down the path of imaging. They're going to get back something that suggests that they may have a sarcoid or a myocarditis. If they're the myocarditis pattern, that's a whole different discussion.
Yeah.
But if they're the sarcoid pathway, then we should be thinking, let's get a genetic cardiomyopathy panel.
Right.
And then depending on how that comes out, 21%, roughly 21% in your paper, and I guess probably other papers are showing this is something that we then need to think about. Could it be a genetic cardiomyopathy? And then from there, where do I go? Now I've got this gene package back and it's positive for one of these genomic cardiomyopathies. What's the next step for the simple cardiologist that's trying to sort through?
Right. Now you have this added complexity, right? That now there's a gene positive. So number one is it's important to have informed conjoint decision-making with the patient. and explaining to the patient, if you were just convinced this was sarcoid, I mean, you could very clearly tell the patient that patients with sarcoidosis can, respond to immunosuppressions. I'm going to start you on immunosuppressive therapy. And mostly, I mean, this is best done in tertiary care centers that deal with immunosuppression, because you really have to monitor these patients, with blood work, and make sure they don't develop infectious complications, if it's steroids, osteoporosis, etc. So they're well-geared systems. Like within Mayo, we have a very comprehensive, well-planned follow-up for these patients who get put on immunosuppression. But now, if you have a gene-positive inflammatory heart disease, you really have to discuss with the patient that there is no data, to support giving you immunosuppression, but you do have active inflammation of the heart. We could go down the path of immunosuppression, or we may not. Immunosuppression includes, all these side effects and the possibility you may or may not get better. And not going down the path may not, necessarily attenuate your disease, because it's a real unknown. And so really, treating the phenotype, whether it's arrhythmias, so if you have to give amiodarone, nexilidine, VT ablation, ICD, all those rules should be followed by guidelines. If it's a reduced EF, putting patients on ACE/ARB, ARNI, beta blockers, all those therapies don't change. So really following guideline-directed medical therapy, whether this is an arrhythmia, conduction tissue disease problem, or heart failure-reduced EF, is the way to go. The immunosuppression question, a general cardiologist is best served by referring this patient to a specialized center. Typically, centers that do heart transplant are well versed with immunosuppression. Mm-hmm. So those type of centers would be geared to dealing with these patients.
And I'm kind of guessing from what you've told us that maybe next steps are going to be some randomized controlled trials.
Right. Or at least starting off with a registry, where people have these patients characterized, and then the outcomes are tracked.
Fantastic. Well, I've learned a lot. The fact that, you have to go down the imaging path first and then classify if you have this, it looks like an inflammatory cardiomyopathy, make sure you get genetic testing.
Right.
Is that something that's commercially available that I can just order for my patient through Epic or some other medical record system? Or how do we order the genetic test?
Yeah. So it's best now. Within Mayo, we've developed a system where we have an intervention, actually, where patients are shown a video, which is recorded by the genetic counselor. So they undergo counseling. And the advantage of the video is we don't have to make a separate appointment with the genetic counselor, which we found a lot of patients don't want to come back for. So we do have that. And then we can, and the heart failure nurses actually fill out all the paperwork for the genetic testing. But for the average practitioner, really referring them to a genetic counselor, and their web pages, you can do a search, find a genetic counselor, and within the area that you live, you can identify a genetic counselor and refer them to a genetic counselor, and they'll take care of it. They'll counsel the patient, and they'll order the genetic testing, get the results back, inform the patient, the physician, and it can go from there.
One other question that just popped into my head, and that is age of these patients. Are they typically, is there a certain age range that would be more classically associated with the genetic cardiomyopathies?
Yeah, it's really a good question. I mean, generally speaking, there are a couple of things that increase the yield of genetic testing, if you may, of it being positive. So one is a familial history. So if there's a familial history, one or more relatives who also have cardiomyopathy or arrhythmias, then the yield of genetic testing can go up to 40%. So, up to 40% chance that there may be a positive finding by genetic testing.
Wow.
But if there's no familial history, and this is really important because people refer people for genetic testing when there's family history. But if there's no familial history or family history, up to 20% can still have a gene abnormality. So that's kind of, and generally people think when you're young and you have arrhythmias or cardiomyopathy, I think the yield is higher in younger patients with severe cardiac disease. But again, just like family history present or not, the yield is not as high in older patients, but it's still there. So we don't necessarily use an age discrimination to do genetic testing. Because, for example, a lot of the titin, the most common abnormality that causes cardiomyopathy is titin. Older patients can present even in their 70s with a titin genetic cardiomyopathy.
That's very interesting. It's sort of the similar thing to one of my areas of interest, and that's hypertrophic cardiomyopathy. We used to always think it was a young person's disease. And over time, we've realized that many of them don't show up in sixth, seventh, and even or I've diagnosed it in 80-year-old, 86-year-old. So I think these are fascinating areas. And the more we know about genetics, the more we're finding how many things are associated with a genetic origin. And so that's really fast. Is there anything else you'd like to clarify or anything else you'd like to leave the audience with, take home points?
Yeah, I mean, if you have a patient with new onset heart failure or significant ventricular arrhythmias or AV block, obviously, PET, MRI, imaging studies that you would do to rule out inflammatory heart disease. And if you find inflammatory heart disease supported by imaging, then obtaining genetic testing, I think, is an important next step. So then we understand, even if patients are immunosuppressed, whether they're gene positive, gene negative, what the outcomes of these patients are. And we hope to build a registry to track these outcomes.
We need more information. So,
exactly.
Wow, very interesting. But from my take home as a humble clinician, you're still going to treat them with guideline-directed medical therapy, phenotypic guideline-directed medical therapy if they're low ejection fraction arrhythmias and these types of things. You would then jump in with those. And then hopefully, if it's an inflammatory cardiomyopathy, sarcoid, or a genetic cardiomyopathy, refer to a center that has transplant capabilities, so usually be tuned into this.
Absolutely.
Would that be a good summary, you think? Or?
That's a beautiful summary.
Thank you.
Thank you.
Well, thank you for your expertise and for all the cutting edge research you're doing in this area to help us better understand this complex group of patients. Thank you so much.
Thanks, Kyle. It was a pleasure.